I'm a senior lecturer in medical imaging at the University of Exeter. I've been there for over 11 years now, and kind of wide-ranging interest in medical imaging as well as AI. But today I'm going to be focusing on a really exciting collaboration with a company called Ibex Innovations, and also more in recent times with Truro Hospital as well. And it's about opportunistically identifying people at increased fracture risk from typical radiographs. So a bit of background on the problem. We're talking about osteoporosis. So which is our bones can be susceptible to fracture for a number of physiological reasons, but the primary reason is reduced bone density. And so when we're diagnosing osteoporosis clinically, we typically look to take a measurement of bone density using a test called a DEXA scan. And there's also some clinical algorithms. The most common one in the NHS is called FRAX, which uses clinical risk factors to estimate fracture risk. It's important that we can identify people as early as possible who are at increased fracture risk, because there are treatment options available. There's lifestyle interventions, vitamin supplementation, but as well as pharmaceutical interventions that can help preserve bone density and reduce fracture risk. But the clinical picture, it can be difficult. Too common in the NHS, we're identifying people after their first fracture, and having a low impact fracture is a huge risk factor for subsequent fractures. And even when people do have a fracture, through our research, I've met a lot of patients who've really struggled to get access to a DEXA scan to diagnose osteoporosis, even after having a fracture. And there is inequalities across the UK in terms of access to DEXA, and it does affect regional areas such as the Southwest. And on the flip side, again, if we can identify people earlier, then there are actually interventions which can help reduce future fracture risk. So this has become really topical in the last kind of couple of months. A couple of headlines I've put a snapshot of here. The Society of Radiographers have put out a kind of statement around the poor provision of bone density scanning in the UK. In terms of access per population to DEXA scanning, the UK is quite poor compared to other European countries. There's only one training provider for DEXA scan reporting in the UK, and they paused their program for a couple of years over COVID. So there's some real issues in terms of access to DEXA, but also planning for future provision. And then you may have seen last week there was NHS approval for a new drug called abaloparatide. But interestingly, at the time, the CEO of the Royal Osteoporosis Society took the opportunity to flag that although it's great to have access to new drugs that can help reduce fracture risk, actually getting diagnostic scans for patients to kind of unlock access to these drugs is still a real concern. So that kind of brings us to the gap that the Ibex Bone Health, or I'll call it Ibex BH software, is trying to fill. So the vision is that when patients are having kind of plain X-rays, typical X-rays for other clinical reasons, that the software can provide an indication of their bone density at that point of care. So we can opportunistically find people at low bone density, ideally before they have their first fracture, whilst they're having X-rays for other reasons, most commonly maybe arthritis or joint pain, those sorts of indications. So the product does use aspects of AI for bone segmentation, but it's also primarily a computationally heavy software, in that it's looking at the detector signal that the image receptor receives, and it knows the exposure that the X-ray machine is output, and it can back calculate a model of the anatomy that must have been present in order to have generated that pattern of detector signal. And from that model, create a marker of bone density. So yeah, I'm going to, just in a few slides, kind of talk about this journey. Ibex is quite apt. You can see Ben from Ibex smiling as we have the analogy of an Ibex climbing the carefully balanced path up a cliff. and trying to avoid, Professor Yang mentioned the kind of valley of death before, from a conception of an idea to clinical implementation. So we've been working for IBEX for 4 years, and it was at least another 4 years prior to meeting us at Exeter that IBEX were working on the underlying physics and the computer modeling behind the software, before coming to work with us in Exeter in kind of first in human studies and also patient engagement. And from that work, which I'll present in the upcoming slides, that's presented us with the opportunity to work with Truro on some of the next steps into making sure that clinical implementation is effective. So the first study that we worked on with IBEX was called the Offer-1 study, and we focused on wrist radiographs primarily. So we looked at 261 participants where we imaged both wrists with a PA radiograph, and also took DEXA scans of each wrist, as well as what would clinically happen for a DEXA scan, which is a scan of your lower back and each hip. And we also took medical history around bone health and in particular relating to that FRAX algorithm that I mentioned earlier. So just before I go on to that slide, so you can see the two regions of interest that we were interested in. We've got the ultradistal region of interest close to the wrist joint itself, and what we call the distal third of the radius. So these are the regions of interest that are used clinically in DEXA scanning. So it was important that the software was analogous to that. So if we look at the ability of the software to predict bone density, this is comparing directly to that wrist DEXA scan, and the red dots are that ultradistal region of interest, which naturally has a lower bone density than the distal third. And we saw a really strong correlation in the ability of the software to predict bone density at the wrist. But perhaps more importantly, clinically, we scanned the spine and the hips. So we looked at the ability of the software to predict that a clinical treatment decision based on what we would consider the gold standard at the moment in clinical practice, which is use of the FRAX algorithm, which incorporates your clinical risk factors like age, gender, and other lifestyle factors, as well as that DEXA result at the neck of femur of the hip. And we could see that the software had a very strong performance at predicting clinical treatment decisions. So that's quite good, obviously, from proving that the software works, but it's a long step from having a software that works to something that's kind of embedded in clinical practice. And we're quite passionate about having a patient voice in our research. And we have PPI representatives on our Exeter research team, as well as at IBEX Innovations. And we actually did carry out some focus groups on patients' perceptions of opportunistic screening of osteoporosis, because whilst it's intuitive, perhaps, well, it'd be interesting to get your feedback, but I would personally want to know if I had osteoporosis in a situation like this. But there's a lot of nuances to it. I think patient users generally agreed it was a good direction to go, but probably similar to a lot of AI applications and research in this space, our patients raised some concerns around, how data is held. It was interesting, the loyalty to the NHS, and there was worries about increased burden on the NHS, for example, and I'll touch on that in a little bit more detail. But probably what came through the strongest was people wanted a human voice in terms of how results are communicated and how treatment decisions are made. And that's particularly important with bone health research, because especially in this situation, if you have someone who hasn't had a fracture, is asymptomatic, and then you tell them they've got osteoporosis and that you recommend they take treatment, it's going to be really important how you communicate fracture risk to them if you want them to stick with that treatment into the future. So yeah, there's a couple of headlines from the research we've done so far, but I'm just going to move on to how helpful it's been collaborating with Truro, taking the next steps into having a software that works, having a general movement of support, but taking that next step into trying to get it into a clinically based study. We've been working with Truro for around a year now, And there's a number of stakeholders who we've needed to engage with if we're going to translate the software into clinical practice. Obviously, staff radiographers and radiologists within the department, but also talking to referrers and in particular GPs, as well as the logistical side of things, our IT and PACS networks, which the software would need to integrate with. We're planning and applying for grant funding for a clinically based study, but we do have arrangements to actually just troubleshoot the software on clinical data, which has been hugely informative. Things like making sure it fails safe. So if somebody accidentally puts a foot X-ray through and it's coded as a wrist X-ray, that the software will identify that and fail safely. And we've also been able to get some audit data from the trust, which has really helped to highlight the treatment gap that exists. So I'll present some data on that in a moment as well. So this just is outlining the kind of broad strokes approach to opportunistic screening. Obviously, we already have pathways to identify people at fracture risk, and in particular, Truro has also just recently started a fracture liaison service where healthcare professionals actively seek out people who've recently had a low impact fracture and carry out bone health assessments on those patients. And we're interested in how the software, the IBEX software, can also integrate into patients where they have had an X-ray, specifically at the moment of wrist X-rays, and whether we can flag up people who are at higher fracture risk and integrate them into existing pathways. So this was some data from a audit of practice at Truro. And whilst it is Truro data, I don't think this is a situation that's unique to Truro. I think you'd see very similar patterns across the UK. And over the last year, we looked at how many wrist X-rays were taken at Truro. You can see here. Oh, I pressed the wrong button there. Can we? I think I've pressed the stop button. Oh, there we go. Of the 2,719 wrist X-rays, 36.2% had a fracture. This is in an over 50s population, so the strong majority of those fractures would have been falls from a standing height, so what we would call a low impact fracture. Only just under 20% of those were referred for a DEXA scan, of which around 28% actually went on to treatment. So it is just audit data, but and there's some kind of crude assumptions there. But if you look at that, roughly 80% of patients who didn't have a DEXA scan, but did have a low impact fracture, there is a treatment gap there of people who could benefit from osteoporosis medications who were potentially missing. What was equally interesting is in those people who didn't have a fracture, it's understandable that less of those went on to be referred for DEXA scan as they didn't have a fracture. But of those who did, it was interesting that the osteoporosis treatment recommendation rate in those patients wasn't particularly lower. So thinking about the application of the IBEX product, there is still a large treatment gap there that we could potentially identify people at increased fracture risk, even if they didn't fracture on that initial X-ray. So just extending on to that, we've looked at some health economic modeling and potential kind of workload impact. Our patients identified it, and naturally our clinicians also identified that if we're going to introduce opportunistic screening, then naturally do we have to worry about an overloading of our DEXA service provision in the first instance. So looking at comparing the current situation, which is based on that slide I just showed you, the very high patients are those who are osteoporotic, but that the FRAX treatment guidance would also recommend a consultant referral to a rheumatologist and for a higher level of kind of anabolic drugs such as abaloparatide that I mentioned earlier, with the other kind of high-risk patients being patients reaching the osteoporosis threshold. So if we look at a situation like the audit we just did, where we look at all patients over 50, and if we look at any patients whose T-score, which is how many standard deviations away from a young, healthy population mean, so minus 3 standard deviations below that population mean is what we're interested in high-risk people. We would naturally be referring a lot more people on to DEXA, but of those people who are going to DEXA, we're being much more efficient with our DEXA service provision in screening the right patients to DEXA who are more likely to require treatment. But naturally, there might be some concerns that I've already mentioned. DEXA service provision can be tricky. So one of the ways that we can use the software is on a case-by-case basis, come up with novel pathways that are the right balance between service provision. And if we look at a similar situation where we just change the threshold of who we refer to DEXA, so in this case, we're really interested in finding those a really very high risk of further fragility fracture, just by changing that threshold to a kind of more extreme T-score that we're interested in. We could see that in a situation like that, we wouldn't actually be referring or impacting DEXA service provision, but we would be making sure we're sending the right patients to DEXA. Because on the flip side of that, if the software is identifying people at a low fracture risk, that they're not getting passed on to DEXA. The last subgroup here is just because it was topical in the news last week, was looking at patients who might be eligible for a baloparatide. So females over the age of 65 with that T-score of -3 at the wrist. And bear in mind, this would be a much smaller subgroup. You would be sending more of those patients to DEXA, but as a high-risk subgroup, the benefits again would be that you're sending the right patients to DEXA and getting them onto a treatment pathway. So we have used some of this data to also look at cost effectiveness, and there's a preprint out there if you're interested in looking at it. Looking at that scenario that we presented with the audit data of looking at males and females over the age of 50 and applying the product to wrist x-rays. Looking at over the lifespan of patients, there is a cost reduction of £109 per patient. And that's primarily because of the high cost of fragility fractures. So in particular, neck of femur hip fractures have obviously a high impact on patients, a high morbidity and mortality, but also cost the NHS a lot of money. On the flip side of that, the imaging we're talking about and the pharmaceutical interventions we're talking about are relatively inexpensive in the scheme of things. And so again, that's the kind of broad overview, but within that paper, we did look at targeting specific subgroups. So if you do look at just tailoring the service to higher impact patient subgroups, then the benefits increase because you're finding the right people and preventing fractures in the right subgroups. Okay, so this is some of the trade-offs and balances that we're working through with Truro. And as Pierre, it was interesting listening to your talk about developing your product on femoral intervention, but you can have a product that works great, but if clinicians don't want to adopt it, then you've got a problem. So we've been very much trying to work with Truro and the radiology staff at Truro at how they see the product being integrated. And across other AI applications I've seen as well, where it can be quite fickle because radiologists are reporting so quickly, and just the look and feel of a software can be really important. And if it takes 2 or 3 extra clicks, it can prevent people from engaging with your product when it comes to medical imaging softwares. Obviously, we are being disruptive, and we are trying to find more people at risk of osteoporosis, and we're passionate about that. But it's important we're realistic and we're integrating into existing pathways and and in that sense, we can bring clinical staff along with us. There's a long list there of the stakeholders we're continuing to work with, both within and outside of radiology, but then also just in terms of making clinical trials happen, we found the R&D team here at Truro been really receptive to working with us, and that's been fantastic. Just alongside our collaboration with Truro, we're also expanding the application into other body regions. So we've been looking at wrist x-rays, and we're also collecting data as we speak on ankle, knee and hip x-rays to expand the application of the software. And alongside our clinical work, where the product does continue on its journey in terms of it has been approved for, it's been CE marked for the wrist software. And we have been working with AGFA, who've released an application of the software, which is branded as Density Scan, powered by IBEX, and AGFA have been really helpful in helping us integrate into Truro as well with the AGFA kit that's here at Truro Hospital. Okay, so I'll stop there, and just before I do, I just obviously want to acknowledge all the help we've had at Truro, in particular Daniel Kim and Tom Bean, who are musculoskeletal radiologists, and Dan has a particular AI interest. Just like to extend thanks to the IBEX innovation team and also the team at Exeter have been working tirelessly to collect a lot of the data that's backing up the IBEX software. And yeah, hand over to any questions.
I think you'd all agree this is quite a novel concept to have a screening for wrist fractures, and I think that's something I think all of us as we get older will be wanting to explore. Anybody got any questions, particularly anything from the floor? We'll just get the microphone up to you.
Yeah, thank you. Fantastic. I just want to know about your experience when you were analyzing the data, what issue you faced. I mean, how did you deal with all the challenges inside the data? Would you explain about the type of data and how did you deal with the issues? Yeah. Thank you.
Well, in terms of, I suppose I might approach it answering the question in a different way, in that the research we did at Exeter, we had very ideal data because we had a volunteer population, and we took our x-ray, we had very good radiographers, and we took our x-rays in a very protocoled way. And the challenge and what's been useful with these initial stages working with Truro is we also have very good radiographers, of course, but there's a wider range of radiographers who vary their practice, and you're looking at real world patients where radiographers being flexible with their technique, and so image orientations, appearances are also highly variable, and so it's been useful to troubleshoot the software that it's responsive to that. Also, I mentioned that the product is physics based, so there is a kind of calibration process that's required for each individual X-ray system within the hospital. And so again, at Exeter, we've been just using one kit, so we can do that in a very protocol way. And it's been useful to work with Truro on a number of different kits in making and essentially refining that calibration process, because again, if we want to work with clinical departments, we need to make sure that we can come in quickly, not disrupt normal service, and be able to calibrate systems for the software efficiently and in a kind of user-friendly way where we can use the clinicians to help us. Yeah.
Kenneth, would you get the microphone across to you? Jenning, I thought this was well, perhaps this was more aligned with your confocal work. I will maybe later.
Yes, no, doing well.
Thank you for the talk. Just to clarify further, based on your recent comment about the calibration of the software, I've seen that some of the pictures you showed, it was just the wrist you were involved with. Is this meant to be used for any other parts, other bones on the other part of the body, or just for the wrist? And also, if you're going to use it for other parts of the bone, how do you intend to deal with the variation? Maybe because now you are relying on the bone density based on how the X-ray is able to penetrate to the bone or maybe reflect back and then measure some. So how do you intend to kind of normalize this to be used for maybe different patients that probably there may be a variation in the density of their bones or maybe other part of the body that the variation in density may differ? How do you intend to deal with this?
Yeah. So we did focus on wrist initially, but I mentioned we are collecting data on other body parts, ankle, knees, and hips, and in particular the hips are a key area because DEXA scans and tools like FRAX use hip DEXA results. So if we can get like-to-like performance, that would be key importance. In a roundabout way, what you mentioned, the way X-rays interacts with the anatomy is actually a key to the product and how it works. So the differences in how X-rays scatter and interact with different anatomy allows the software to, again, look at the scattering profile that the detector receives and kind of back calculate how the anatomy must have been, what proportion of bone density compared to soft tissue density there must have been. So in a funny way, the software actually depends on that difference in how different participants' anatomy interacts with X-ray. So that does add a challenge in I mentioned that you have to have a very calibrated system that you're very aware of the performance of your image receptor. But I think it's an advantage in this kind of market because you could imagine and people are doing this. You can have a product which is more like a pattern recognition AI where you give it 20,000 wrist X-rays and you know their DEXA result. But if you're talking about different X-ray systems and just using grayscales as a marker of bone density, and you're talking about digital images which can be post-processed in many different ways, there's limitations to that more kind of typical whole-scale pattern recognition approach to AI. I hope that answers your question.
Thank you.